Great. So thanks so much to everyone for joining. This is the first of our webinar series for the Upsides project on peer support in low and middle income countries and also non-Anglophone countries. So we're really excited to have Jasmine and her team from Pune coming to get us started. Thanks so much, Jasmine. Over to you.
Thanks so much, Grace, and thank you everyone for joining in. Okay, so I'm just gonna get straight to it. So what we'll be talking about today is just our experiences of doing peer support in India through 3 different projects. I work at the Center for Mental Health Law and Policy, which is based in a city called Pune. So how the webinar has been planned is that we'll just try and set some context to kind of just say what our perspective is when we look at this mental health care gap, and share with you some of the work that we've done around Quality Rights Gujarat by introducing peer support in a formal setting of mental health care services in Gujarat. We'd also like to just introduce you to another peer intervention that we're doing in a community-based setting in rural India, which is called the Atmiyata model. And the new interventions that we've just started about this year itself, which is called Upsides, and then kind of move into what sort of challenges that we've had and what are the learnings that we have and what we plan to do in the future. So the presentation is divided in a way that we'll try and give some time for discussion or for you to ask questions after each of these project introductions. So I suppose logistically, if you need to ask a question, I suppose you can just drop in the chat. So I'm not too sure Anisa and Grace can help with that.
Great. Yeah, absolutely. If anybody has a question that arises during the presentation, feel free to put it in the chat box. And then when we take a break for questions, we'll have them all nicely lined up.
All right, super. Okay, so so we can move to the next slide. So our perspective with looking at peer support was to bridge this mental health care gap. It's intentionally called the mental health care gap and not a treatment gap because of a certain ideology that likes to look at the mental health care gap being broader than just the traditionally understood notions of having enough psychiatrists and psychologists and healthcare services in place. While we think that is very important, we also feel that there needs to be equal and more emphasis on effective psychosocial interventions that have been proven to be evidence-based and have found to be effective. And we also think we need to address the issue of physical healthcare gap, which usually gets neglected for people with psychosocial disabilities. So our conception of mental health care gap has been slightly more broader, more holistic, to look at all of these different aspects that need to be filled in to then eventually look at how we can reduce this gap. The second issue that I do want to highlight is that we don't think mental health is only linked to a health systems issue. We do know there are lots of social determinants and antecedents to mental health which are based in the social. So if we do need to do something to reduce that gap, then we need to be more creative and we need to put more emphasis on a more systemic and structural perspective, especially when we're talking about LMIC context. The other issue that I do want to highlight is that we think mental health is also intersectional. So it does need to take into account that mental health does impact people in a different way, depending on where your standing might be within the social context of based on your gender, your caste, specifically in the Indian context, your religion, and where you are based. So therefore, if we're talking about this mental health care gap, then the mental health support is not built in a vacuum. It needs to think of various innovative, effective psychosocial interventions, which look at social determinants also and are not limited to a standard traditional medical view that we have. So that's the kind of brief background of how we have been functioning. The next slide is talking about our approach. There are things that we value as an organization, and that's how all of our work is planned, which focuses on participation, which needs to be by people with lived experience and not just this traditionally understood notion of an expert that perhaps has traditionally also silenced a lot of voices of people who need to be at the forefront. We believe in innovation. We believe that in an under-resourced setting, if we really have to look at this care gap to be closed, then we would need innovative, effective interventions. We like the idea of thinking of plural perspectives, of being interdisciplinary and not limiting it only to a health systems perspective. And our work has been guided by the issue of parity to say that mental health needs to be looked at, and I think it's high time that it's not an ignored issue that we look at. So what we're going to do today is talk about 3 interventions. I'll begin by Quality Rights Gujarat. The reason for doing that is because we started with our peer support work through this intervention. And then I'll talk about another community one and then upsides. So moving to Quality Rights Gujarat, those are all our collaborators. And the next slide will show you it was done from the period of 2014 to 2016. It was funded by Grand Challenges Canada. And it's WHO's framework to address the issue of human rights violation across mental health care settings globally. And some of the core values that it follows was to say that we need to improve the social environment of mental health care services by using available resources, but also advocating for more resources wherever required. It focuses on capacity building for not just health workers, but also people with lived experience, family members, for changing attitudes and practices. The focus being that there should also be a change within practices and not just training for changing attitudes. And the whole way in which it was functioned was to build local capacities. So we have a pool of members who are trained as master trainers who can train other staff members too as an ongoing process. The third thing that the project did was to build family and peer support groups. And I'll talk about this a little bit more. And the last thing that we focused on within the project was to change facility level policies and mechanisms to make them more aligned with human rights principles. And all of these activities actually were aligned to build quality improvement with the assumption that if you do improve your quality, you should see a reduction in human rights violations, and they both are intrinsically linked. So that was the project background. We did this across 6 intervention sites. The first one is relevant because that's where we're running our latest intervention. So the first 2 are large public mental health facilities, which have about 300 bedded hospitals with an inpatient of, with an outpatient of about 100 to 150 per day. The third one is also a mental health facility, which is based on the border of Gujarat, which also sees a lot of people. It has a capacity for 40 beds, but it's usually over-occupied. Then the next one is, it was a smaller hospital, which is now built into a specialized service. And so Mehsana, the civil hospital in Mehsana will be relevant when I speak about Atmiyata. And the next one was the civil hospital at Surat, which was a medical college, and it had an outpatient and inpatient unit. And similar was the structure for the last facility. So this is just to give you a broad idea of where the intervention was based. So what was the quality rights interventions? Like I said, that we did an improvement of the social environment, which looked at how people interact with each other, what sort of system should be put in place if we need to look at human rights violations. So there was a participation by all of the staff members, service users, and carers who come and access the facility to think about what change would they like to see. So we created some improvement plans. And based on these plans, there was some amount of capacity building that was done using the WHO's modules, which were adapted to our context. There was also setting up of the family and peer support groups. And then we changed a lot of policies around how the hospital was functioning. So for example, at one of the hospitals, they didn't have a very good complaints redressal policy. So they created a whole system of how people could give feedback to the facility, how they could improve the notion of nutrition for people who are living in those facilities. So that was what the intervention was about. But what we did do as part of using this as an opportunity was to say, if we do need to think of services to be recovery oriented or rights oriented, then there needs to be a forefront of people with lived experience to own that process. And so one of the reasons for introducing peer support within these facilities was to say, we need to create some amount of platform, which is a formalized space where people with lived experience have some amount of voice or some amount of say, to think about what these services should look like. We also recognize that our current healthcare services are designed in a way that there is a certain overburdening of the present healthcare professionals. There's also lack of capacity for them to deal with all the burden that comes with tertiary care services. So then the innovation was to say, how can people with lived experience support other people in their recovery journey? So that's how we introduced that. The idea was that they work part-time, that they help people fill up their recovery plans, or at least think through their recovery plans. They were also involved with forming for the first time peer support group meetings, which had never happened previously. And then they would lead these meetings, they would organize them, they would create an agenda, and then lead that process of change. They also were helpful in building a bridge between professionals and people with lived experience to kind of find some ways in which they could communicate how they were feeling, and also communicate the message of hope and share their personal journeys. And then we did this slightly minimally, but to say that how they could assist people in accessing their social benefit if they had to come and attend the support group, for example. And the basic premise was that how do you inspire hope by sharing your own personal experiences, because this was a space where these kind of narratives were not given enough in most space. So this is from 2014 to 16, we had about 27 such peer support volunteers across these 6 sites. So before I go on, the easiest way to understand the intervention is by hearing from one of our peer support volunteers themselves, and who's called Janki Patel. We're just gonna switch platforms and let you hear the video. We have some problem with the audio, but the subtitle should be helpful.
પછી તો મને એડમિટ કરી હતી. એડમિટ કર્યા પછી મને ત્યાં સ્ટોક આપવામાં આવતા હતા પ્રાઇવેટ હોસ્પિટલમાં. તો એનાથી મને વધારે તકલીફ થવા માંડી. અને અત્યારે હું પીએસસી તરીકે ક્વોલિટી રાઇટ્સ પ્રોજેક્ટ નામના પ્રોજેક્ટમાં પીએસસી તરીકે કામ કરું છું. પીએસસી मतलब पीएस सपोर्टिंग वॉलंटियर. हम वॉलंटियर का काम करते हैं, जो स्वयं सेवक मतलब दूसरे पेशेंट को हमको कैसे समझाना है, उसका ट्रिगर्स जानना है, उसके लक्ष्य के बारे में, उसकी जिम्मेदारी के बारे में, उसकी सुखाकारी की योजना और सब प्लान में जो स्टेप्स है उनके बारे में हम उनको समझाते हैं, उनके साथ प्यार से बात करते हैं, उनको आशा देते हैं कि आप भी हमारे जैसे अच्छे बन सकते हो और आप भी कुछ ऐसा अच्छा मतलब आगे जाके आपका लक्ष्य पूरा कर सकते हो, आपकी जिम्मेदारी से आपका जो अपने जो टैलेंट है वो आगे ला सकते हो, और ऐसी तरह हम उनको हेल्पफुल करते हैं। मेरे जीवन में तो बहुत बदलाव आया है। मैं पहले कुछ भी नहीं करती थी, 11 बजे उठती थी, खाना खा के फिर सो जाती थी, घर में कोई हेल्प, मम्मी की हेल्प नहीं करती थी या फिर कोई जॉब नहीं करती थी। तो अब तो मेरी मम्मी भी बोलती है कि तू अच्छी एक्टिव बन गई है, और घर के सभी सभ्यों में बोलते कि ये अच्छा काम कर रही है तू।
Thanks, Anisa. Well, that was just to give you a brief background of what our peer support volunteers had to say about being a part of this experience. This one, I just wanted to highlight that while I'll speak about this total of 35 PSP accommodations that we'd made, but however, there were only 27 people, and I'll speak about the issues with that. So, while Janki has already explained this, just to brief you that there were two broad principles that we hope that the peer support volunteers could do. There's also a reason why they're called volunteers is because you couldn't add them as workers, because then that requires a certain amount of guidelines and processes if they're part of the government system. So essentially they were required to fill in the recovery plan, and if we move to the next slide, it kind of lays out what the recovery plan included, which was about how do you think about your dreams and your goals, which we realized was a very difficult task because most of the people wouldn't know what their dreams and goals were, which is also understandable that it's one of those questions which perhaps was never asked in that healthcare setting or even within their personal setting. Then we focused on how do you develop your own wellness plan, how do you manage your ups and downs when you know you're not feeling very well, plans for a crisis and plans for after a crisis might have happened, and then how would you like to address it the next time you probably are feeling distressed. The next one just tries to give you an overview of how many peer support group meetings happen. So across the 6 sites, the good news was that we were able to form support groups, which had never happened, and which were also slightly harder to attend because people would often come with their caregivers. So we tried to do an accommodation by having a service user and a caregiver meeting at the same time, so that there would be a separate space for people with lived experience to share about their experiences. And a lot of the meetings were around that, where they could share their experiences, get some practical advice on how to feel better. There was also more concrete things such as benefits that they were entitled to. So that was a range of experience that we had. And I do know that some of these support group meetings have continued to exist even after the intervention ended in 2016. The next one was just to kind of summarize what were the changes that we saw. The biggest change that we did see was that we managed to include peer support volunteers' work within the state financial policy. So while the project was ongoing, the project sustained the remuneration that the peer support volunteers received, but this was moved on, and the State Mental Health Authority has sanctioned 35 such positions for people across the state to formally be a volunteer within these health spaces. So that was a huge win for us. Like I said, the work on peer support and the peer support groups has continued even after the implementation, which we feel is a sign of ownership of the intervention by people themselves. We also saw some of the peer support workers forming their online pages and WhatsApp groups, which also increased their relationship with people that they'd never known in the past. There was also a lot of activities that the peer support volunteers introduced, and the staff allowed them to do so. A lot of our peer support volunteers then did this work for some time and then moved into a more formal employment space, which gave them more of a guarantee of long-term employment, which showed that there was a difference in how their relationship with their caregivers was. We saw that people were far more proactive in going to the head of the facilities, speaking to them, asking for change of certain services. And across some of the sites, there were some really supportive staff members too. So what I'm going to do is move to break here for some time for some questions, and then move to a different setting of a peer support intervention and come back to the challenges that we face with quality rights. So we can pause here.
Great. I'm going to unmute everyone. So, oh, we have a question, Jasmine, from Jason. What were the outcomes of the interventions?
Yes. So as part of quality rights, we did a pragmatic trial, and some of the brief findings that we had more satisfied with their services, and they felt they were recovering better. In terms of the staff perspective, we saw that most people who had reported coercion to be seen as a necessary thing to do as part of treatment now started seeing coercion as a form of a human rights violation, and therefore started thinking about what needs to change within their practices. In terms of the measurements on the caregiver side, we saw that people felt, we used the Zared burden questionnaire, which showed that they felt that they could now provide effective care and support to their relatives. So we did more of the analysis at a services level, not so much the specific aspect of peer support.
I think there was a follow-up question to that question.
Yes. Yeah. So the question is, have you followed up after 1, 5, 10 years? So the intervention ended in 2016, and the upsides intervention that we started in 2019 was actually to follow up on some of these interventions that we'd introduced. So I'll speak about the upsides intervention, and that's specifically for the peer support one. In terms of a broader overview of what happened to quality rights in these facilities, a lot of them had incorporated the quality rights capacity building modules and the improvement plans as part of their day-to-day functioning. So anytime a new staff gets recruited, they use some of these capacity building modules even now. There's also been some conversation with the WHO India office to think about scaling up the intervention nationally. Yeah, so we found that wherever we had effective leadership across these facilities, they adopted it within their day-to-day practice. So the adapted WHO modules. So we were the first site where the entire scaled up intervention of the WHO modules were used. And I know that they've been through revisions now, and the latest modules are slightly different than what we had used. But broadly to say, we did try and contextualize it to our settings. So that meant changing some examples, changing the flow, reducing some content that perhaps was something that we thought the facilities wouldn't react very well to. Because at that point in time, the law kind of supported people to be detained forcefully and to have involuntary treatment and admissions. And so then to speak about legal capacity often got us into this whole conflict with the law and what the requirements were as part of the CRPD. The thing that worked for us was the new law was supposed to come in place, which it is now, which allows for people to think of their advanced directives, to think of voluntary admissions, and it doesn't permit things that the earlier law did. So those were the kind of adaptations that we made.
Great. Are there any more questions before we decide to move on?
So I'll probably also come back to challenges that we had in reference to the peer support intervention. So maybe if there's some more questions, we could take it up then.
Wonderful.
Okay. So I'll move to a different sort of a context, which the quality rights was done across public mental health facilities. And the other intervention that I want to talk about today is based in a rural community. It's called the Atmiyata. It's also funded by Grand Challenges Canada and Mariawala Health Initiative. That's where we've scaled up the intervention from 40 villages to 600 villages. So what is Atmiyata? It is a community-led initiative to enable people who are living in these communities to take care of their own mental health care and social care needs. We work through a system of volunteers. It is an innovative solution which uses existing social capital within these spaces to think of what mental health care could look like. We do feel it's sustainable. It's also high impact because you're training people within their own village settings to have enough skills to reach out to people who are in distress and deal with their issues. In terms of the figure that you see on your right, it's based on the WHO pyramid of care. And if you see on the base of it, it says self-care, and above that, it says Atmiyata, but it actually says informal care, where you see that the need for services is the highest, and also to think about interventions at this level means lower cost of interventions too. And then it moves to more specialized services of primary healthcare, which is the third last tier, and then moves into more specialized services such as psychiatric services, community setting services, and then long stay facilities. Just to put it in context, the long stay facilities where we did a lot of our interventions in quality rights does have the lowest amount of need and the highest amount of cost. But the way our health systems are functioning is that the focus is on the topmost layer and not so much when you move to the bottom few layers. And so our work has been to kind of focus on these last two pyramids, which is informal care and self-care. And Atmiyata kind of sits within those two. So I'll just move on to give you a little bit of context of where we work. This is the map of Mehsana, which is a district close to Gandhinagar, which is the capital of the state. It has 10 sub-blocks, which are called talukas, and they have about 615 villages. So far, we've covered about 450 villages, and we have about 600 volunteers. So the volunteers are people who really lead this intervention, and they are our peer workers in that equivalent sense. So what do our volunteers do? The first thing that they're trained to do is to identify people who are facing distress. And we do this by actually orienting people to look for antecedents to mental health distress. So it could be if someone has either unemployment or alcohol use or domestic violence or conflict within the family or some relationship problems, they will reach out to these people and have a conversation with them. If they think they're experiencing some amount of distress, then they're trained to provide 4 to 6 counseling sessions. And I say counseling sessions, but they're largely conversations that people would have for about 20 to 30 minutes at a place which is convenient to both of the people. And the idea is that they use evidence-based techniques such as active listening, problem solving, and behavior activation techniques. So that's the first role of what the champion or the volunteer or the peer would do. The second thing is that people make referrals whenever they think it's something that is of a more severe issue that they themselves can't deal with. So we make use of the health system that already exists. And as part of quality rights, we'd worked with the local hospital there, who has also been equipped to understand what issues of recovery and human rights are. We've also created certain films that talk about these antecedents to mental health, which they narrow cast and show to about 2 to 3 members in a village setting. And they will have a conversation about what happens in their own context if someone were to be distressed. And that's how they get some referrals, and that's how they begin the conversation on mental health. They also enable people to access social benefits that they might be entitled to. And we have a small application, and we provide them with smartphones to document some of the work that they're doing to reduce paperwork and the pressure of documentation. And the way it is designed is that there'll be one volunteer for about 1,000 to 1,500 population. The next image is just to show you some of our volunteers. We recently had a meeting where about 200 to 250 champions got together and spoke about why they were part of this process. They also got some awards for doing the work that they were doing, so as form of social recognition. And we also called people who are relevant to the community as a motivation factor. In terms of training, there is a layer that supports these volunteers, and that's called a community facilitator. They get about 12 days of training, and the Atmiyata champion, if you see in the second rows, gets about 7 days of training, which we spread across 3 weeks. Since they're volunteers, then we try and fit in within their time schedule to conduct the training sessions. And the champions these volunteers are also assisted by other volunteers, which are called mitras, who might be based in different parts of the villages to identify people who might be in distress and refer them back to the champion. In terms of what we have done so far, this is about a year's data from January 2019 to December, where we reached out to people who were facing mental health distress, which we know is more common mental disorders, is about 10,000 people. For referrals for severe mental illness, we've made about 1,500 referrals to either the local community healthcare service or the district level hospital, or any other helpline that they would like to access. In terms of social benefits, we reached out to about 4,000 people. That means that all of them have now received a benefit of some kind. Either it's related to housing or insurance or a pension or their disability certificates. And about 38,000 people have viewed the film and engaged with it at some levels. So that's just to introduce Atmiyata. We do have another video, but I'm just wondering if we could just take a few questions on that, and then I could move to the upsides presentation.
I actually have a question, Jasmine. Sorry. So you've introduced several different strands of work in kind of a similar geographic area, and it's all really exciting. I was wondering if you have any thoughts on how they integrate or strengthen one another, and kind of what's the role of these individual, usually donor-funded projects in ultimately strengthening a very complex mental health system over quite a large scale.
Mm-hmm. Yes, that's true. So I'll speak specifically about Atmiyata, because the whole idea of doing this intervention was to say, the burden of services seem to be going towards healthcare services, whereas there's so much work that can be done within the community. And it makes no sense to enter the community, give them alternatives, and then walk out after the grant is over or after the trial is over. So the whole manner in which we wanted to introduce the community intervention was to make it sustainable. And the conversations, even before we started the trial with our funders, was to say that if this turns out to be effective, we would hope that this would continue. And the reasons for, so maybe I can speak about the fact that in 2019, we ended the trial. And thankfully, we've also found some sort of a synergy with our current funder, who's decided to fund this for the next 3 years, knowing that the results of our trial have shown that it's an effective intervention. Unfortunately, I can't share the results here because we're just trying to write up the paper and send it out for publication. But just to briefly say that the odds ratio of someone interacting with our champion is like they have 2.2 odds ratio. So that means they have twice the likelihood of getting better if they have spoken to our champion. And these are people who have used their own personal experiences of distress to reach out to people within their village setting and have provided them with enough support through these sessions or beyond to come out of that distress. And it's completely owned by the community. So at some level, the way this intervention is also designed, that even if we didn't have the funds, for example, or even if this was not grant funded, there are enough and more resources within the community and enough social capital within the community to continue this work, irrespective of what would happen externally. So I'm not sure if I answered that completely, but that's the broad idea.
No, I think that definitely answers it. It sort of points to the role of the generation of really convincing evidence in terms of sustaining the work and getting it adapted into sort of government practice and government budgets. But that's sort of the holy grail that so much of us working in research on peer support want to achieve, and yet don't have the sort of receptive response from policymakers to actually then get the work carried forward. So it's really exciting to see these kinds of results from Gujarat.
I think that there's another question.
Yeah.
Sorry. How were these peers sort of selected from the general population, and whether there was any friction between those who had experiences with mental health conditions and those who have not as of yet? From Jason.
Mm-hmm. Thanks, Jason. So how we identify the peers is that we follow a rigorous process of mapping out the village first by the community facilitators. We find out how the village interacts with each other, what sort of informal networks that exist, who are the kind of people that people would often go to when they're feeling, when they feel like they're in a crisis. It could be any kind of crisis. So they will speak to about 10 to 12 community members and try and get names of people who could be potential volunteers. And then they would have an informal interview with each of these nominations that come through. And based on their availability of time of attending the training session and their willingness to do this work, then they're selected. And then, of course, their entire after the training, they're also visited by this community facilitator twice a month, and their quality is monitored over time. So that's the kind of process that we follow. There is no pre-described requirement of saying that you have to have a lived experience to do this work. What we did find was that most of our volunteers who work with us did have previous experience of mental health distress. To be really honest, that was not a pre-requirement. We didn't say that because it's kind of hard to define what that experience should look like in a community setting and how people are willing, how willing are people to share their experiences about their distress too. So it's a more open process, but our experience was that once you mention the word mental health, and if you kind of talk about some experiences of distress, most people who were interested were people who'd been through that position. So we also do have volunteers who might not have had previous experience of distress too. So it was not a qualifying factor, and therefore that kind of got us away from this whole discrimination between those who had and those who didn't. All right, thank you. So in the interest of time, I'm just wondering if we should just go ahead and then, because I have a few challenges that we list out at the end, and maybe we could discuss those too. All right, thank you. So I'm going to move to the upsides intervention. The broad vision of that project being that we do want to think about interventions which are co-designed with people with lived experience, that are feasible and acceptable to them, and definitely think of scaling up these interventions. At the India side, I lead that work. It started last year, and we're still, so we spent all of last year trying to develop certain preparatory phase, and now we're into the child phase. And we have about 10 such peer support volunteers who work at the Hospital for Mental Health in Ahmedabad, which was another quality rights intervention site. So I'm now just gonna go back to the quality rights a little bit to say, while we did have a few successes with that intervention, and especially with the peer support intervention, there was, I guess by just going back after a few years or even during the intervention, we did see that there's a dominance of the medical model versus the recovery model. And this perhaps is not very big news for anyone who's seen our mental health care services. What we did have challenges with was there was no clear role definition of what a peer support volunteer should be doing. We also saw that somewhere where there were very low resources in terms of human resources and financial resources, a lot of our peer support workers were being asked to do what the staff members should be doing. Given the burden of care that the tertiary services already have to deal with, there was a lack of supervision and mentorship that was provided to peer workers. At some of the sites, there was also a difference of opinion of certain staff members not understanding the notion of peer support or wondering why that needed to be done at all. There was also a situation that we got into where peer support volunteers who joined right in the beginning, continued till the end, and there was no sight of them either moving out into different avenues or allowing space for other people to enter the system. So that was a bit of a limitation too. And the major reason also being that it was completely hospital-centric, so there was very little community interaction that happened, which also is reflective of our public mental health systems, which tend to isolate the community and the outside world to this particular institutional setting. So in a sense, why we decided to do this intervention of upsides was to say, we have an entry into the system. We have a situation for the first time that the state has allocated budget for peer support to be run in a state. And to not do anything about it just because the grant was over just felt completely unethical to us. So this became an opportunity to reopen some of those that work that could have been improved upon and could have been worked upon more. So that's why we're part of the intervention. Learning from all of our experiences, we realized that we didn't have enough of standardization, intervention, or protocols around it to think about how we could scale this up. So it just became a very person-centric thing wherever the heads of the facilities were more proactive or saw the benefit of doing peer support, continued the intervention, whereas some of the facilities didn't. So we felt like this is another opportunity to capture that, capture the element of closing the gap by standardizing the intervention, by developing certain policies, even at the facility level, to think of peer support as a more intrinsic part of what they're doing. We also thought this is an opportunity to increase the amount of supervision that they got or mentorship that they should be receiving, which they weren't earlier. And primarily think of how we can co-design these interventions rather than follow the same health system logic of everything coming from a top-down approach. So that's just to give a brief background of why we're part of this consortium. I should clarify that this is a consortium. There are about 8 partners within this intervention and about 6 recruiting sites. I'm assuming one of the webinars will talk about the intervention, so I won't get into the details. So I'll move to what our plan for the implementation is. While we did recognize the importance of one-to-one sessions by peer support volunteers with other people with lived experience, we do feel that that perhaps is not enough to close the gap. So our hope is that through these, the next 4 years that we have, we can build upon this existing peer support group network we had first established And to just say that those peer support groups have completely changed in the way that they function. The focus is more on providing, as the health systems call it, the psychoeducation aspect, which is actually telling people things to do rather than giving some space for them to share their experiences and think about recovery. So we do want to work on that. We're also working on how the Mental Health Care Act can also be implemented using peer support workers, especially by thinking of implementation of advanced directives that the law now permits. There's also going to be more focus on how do you enable access to social benefits, which could be to do with more practical needs around health insurance and disability certificates and other such schemes which they're anyway entitled to. And then we're hoping that if we could build a certain amount of protocol and standardization, we could think about scaling this up, scaling the intervention at least across the state and then move even further. However, there remain lots of challenges of doing peer support within healthcare systems. There's always this, I guess the whole question is that what is this role of a peer worker within this health system design, which is very medically oriented? And then how does one change that perspective towards a recovery oriented perspective? The other question that we've been grappling with is that the idea of recovery is also to move beyond the individual and link them up to existing services that might assist their individual growth. But services such as housing, temporary shelter, education, vocational training, all of these services and networks that exist outside this hospital are also slightly discriminatory for people with psychosocial disabilities. So there are barriers not just at the healthcare system level, but also at the social care system level. We also feel that if the entire ecosystem of healthcare services is not recovery oriented, then the burden of peer support to make these services recovery oriented is slightly huge and perhaps even unfair, because that's not the only thing that can become a bit of a checklist to say that services are now recovery oriented just because they've introduced peer support. There needs to be far more efforts to rethink how services are designed. However, we grapple with those sort of challenges. And the impact of this medical model is also that despite the training, despite the conversation, our peers would often define their experience as being patients, and that's the kind of identity that gets frozen in time. And that's harder to deal with, has been our experience. Some of the other challenges which are more national is that while we do have the new Mental Health Care Act and the National Mental Health Policy that came in 2014, there is no specific mention of peer support, and it does remain as an underutilized service that no one seems to be looking at, despite the evidence that might exist in bits and pieces. And that makes it harder for, going back to Grace's point about advocating with policymakers to give attention to peer support or give attention to recovery, because there's no specific mention in that sense. And also we find that in our context, there's no formalized user-led movement, that also we often grapple with people asking for ways in which they could reach out to different organizations perhaps, and they just don't exist. So that's been another sort of broad challenge that just wanted to highlight here. So I think some of the learnings then therefore are that if you do have an intervention which is effective, which is evidence-based, then scaling up is not an option anymore. I think you just have to do it. It's become more of a compulsion. And I think we owe it to our communities and our services to say, if you do have a solution, then it needs to be more accessible. I think there also needs to be far more focus on understanding the local context-specific research evidence, which in this which can't be speaking to a global North population, but also think of global South evidence and research and understanding of some of these concepts of recovery, human rights, and peer support. I think we just need to think far more deeply on these issues. And like I said earlier, that we need to change our services to reorient them to support rights and to support recovery. It can't be just one-off interventions that will solve this complex problem that we find ourselves in. We also think that peer support needs to be far more accessible. And when I say accessible, not just within these healthcare settings, but also community settings. And within the community, we do know that there's so many social barriers based on your gender, based on your religion, age, and caste. So we can't ignore all of these social injustices that we exist in, and our interventions need to speak to each of these social barriers that we live with. And yeah, more importantly, I think it's high time that we started designing interventions with people rather than making decisions for them, which result in then this whole aspect of doing projects which are not owned by the community, and therefore once these projects and grants end, that there's no sustainability within those settings. So yeah, so that's where I will stop. Those are the learnings and the next steps, and that's some information for our center. And I'll pause here for questions.
Hi, I had a question, Jasmine. It was regarding what you mentioned about how the program is at a point now where there hasn't yet been mention of peer support within the mental health law or policy, but I wonder if you've started to have these conversations with policymakers regarding peer support and how receptive they've been. And on that note, if you had any experiences to share about how others in similar settings could do this in beneficial or even productive or successful ways.
Right. So I can speak about a generic one, specifically more for Atmiyata, because that we've worked more closely with policymakers, and with Upsides, we're not at a phase where we want to reach out to policymakers yet. But our general experience has been that I think if you include policymakers right from the beginning and include them in the intervention and keep them updated on what the project has been about, what sort of challenges you are facing, inviting them to see some of the sites that you've been working on are useful ways in which you can actually build some ownership. Which does require time and effort, and these efforts and time allocations are perhaps not pre-specified when you write up a grant proposal, for example, but need to be an integral part of your intervention if you think of scaling up. The other thing is we've now, how should I put this? So basically, I think we as researchers also need to understand that you need to have a more sustained relationship with your policymakers and not just enter whenever you need something out of them. So we've realized that you need to keep that relationship going. There is a need to kind of orient their understanding, which understandably is different than perhaps what you're introducing. So to find the right words, to find the right kind of things to say to policymakers that make sense to their context, that speaks to their needs, is also an integral part of communicating with policymakers. Our experience of at least Atmiyata has been that they've been rather interested. We recently had the health secretary say that she wanted to scale up the entire intervention across the state. And this happened after a lot of sustained efforts to keep that relationship going, to let her know what the project was about, since it is her area of work and it's her population that we're really speaking to. So I think there's a certain amount of interest that even they have in improving services that exist. So yeah, for us, I think it's been about sustaining that relationship, and we do find that there is a certain amount of interest when you speak about peer support, when you speak about recovery. that they at least want to know more about it. So that's where I will, yeah, that's what I would say.
Thanks. That was really helpful, and it's a good reminder also to sort of engage from the get-go. It's good to know that there's budding interest as well. I think that there's another question on the chat. Did you want to address that?
Sure. So the concept of recovery, and did you work with people to arrive at a joint definition? Is that an idea that was alien? And how does this intersect with issues such as religion? So that's a great point. When we did introduce the issue of recovery that we did over quality rights intervention, there was this whole, how should I say, basically there was this confusion between what is recovery and how is that different from rehabilitation, which is the terminology that is mostly used. But that also became a helpful point to think about recovery, which is not rehabilitation, which is basically letting people choose their options, letting them define what their goals are, where they need to be, whereas rehabilitation is within our Indian context is understood more as a top-down approach of giving 3 options to people and letting them choose between the 3. So it wasn't a concept that was traditionally used, and if it was used, it was also looked at as symptomatic reduction and not so much recovery as we defined it to be. So what we did do was engage during the recovery trainings, engage a lot more time on discussion of this very concept, rather than using it just as a loose term, but having a lot more small group discussions, facilitating their thinking around what do they conceptualize recovery to be, and is that something that could even be thought about. And I think that's where we had this bit of a division on that, to say that this was too ideal is what some people thought, and some people believed that this was possible. And actually, that was one of the main reasons why we introduced peer support, was to say that we need to change this whole vague and abstract notion of recovery into practice. So by actually showing how it could be done by someone, and how they could change their practices also by, rethinking how they were spending time, how they were having conversations with people. So that actually did take us some while. And we're in fact doing this network meeting sometime soon to think about recovery in this global South context, because I feel like it's slightly different, and that's that is what our discussion is going to be. We did struggle with it a lot. I'm sorry, this is a very long-winded response to your question, but we didn't arrive at a joint definition. I think we're still quite varied on what it means within our context. There is also a whole varied division even now to think something between rehabilitation to recovery to rights to just getting well. So it's a bit more complicated, and we're still struggling with it. I don't know if that answers your question, but it is still all over the place.
I think that in general, conversations about mental health and recovery in low and middle income countries is still a bit all over the place, Jasmine. So I don't think that's a reflection on you or your project in particular. I know that we struggle with it at other sites as well, where interventions like peer support, which came out of a recovery tradition mostly driven from higher income countries, are now sort of being grafted onto mental health systems that don't necessarily have a recovery focus yet, and that's a constant tension. So it's interesting to hear you raise that. I think we are kind of out of time at this point. But I just wanted to see if anyone had any lingering questions, and if you don't mind staying on for an extra 5 minutes, Jasmine?
Absolutely, yes.
Great. And in the meantime, just thank you so much to everyone for joining and taking some time out of your day to talk about this really exciting work that this amazing team is doing. And thank you so much to Jasmine for agreeing to be our guinea pig and talk at us for an hour. The webinar will be recorded and it'll be posted on mhinnovation.net and also on the Upsides Project website. So if you have any colleagues or friends who you think would like to see the recording, that'll be up soon.